Activity level assessments are conducted to assign K levels to lower limb prosthesis patients. K levels are a major factor in deciding the prosthetic components a patient is prescribed. There are known issues with the current K level assessments in relation to reliability and consistency. These are more apparent when differentiating between a K2 and a K3 patient. The aim of my PhD research project is to create an objective assessment method to enhance the reliability and consistency of K-level classifications. This research is important because if a patient is misclassified, they could be prescribed prosthesis that could limit their activity. K levels are also a deciding factor for the benefits or insurance payouts a patient might receive. And a sensor-based system that can measure a patient's activity outside of a clinic could help the clinician monitor patient's health and identify any health concerns before they become a serious issue. This presentation covers the initial research for this project. This consisted of a review of past studies that have used a sensor-based system to assess activities, identifying the potential capabilities of such a system and the type of sensors that have shown potential at classifying activities. Interviews have also been conducted with specialists that have experience conducting activity assessments for K-level classification. These interviews explored the requirements of a sensor-based system from a clinical and end-user point of view. Specifically, the aim of these interviews is to investigate the current assessment methods, past studies the interviewees have participated in, and their views on a new sensor-based system. From reviewing past studies, it was shown that measuring step count, cadence, and classifying some locomotion could be achieved with the use of an accelerometer attached to the patient or prosthesis. Step length and distance covered could be calculated from accelerometer or IMU data using a calculation developed by RAMP. Step height and ramp incline has also been measured accurately using ergometers and IMUs on an able-bodied participant. In this study, a single IMU on the shank could detect a ramp but could not accurately measure the incline. A few studies have compared K levels to measured activity levels. From these studies, it was found that between 15 and 30% of patients exhibited activity behaviours that did not align to their K level. Bolkman and colleagues looked at how prosthetists and patients viewed patients' activity levels compared to objectively measured data. The prosthetist and patient's estimates showed no correlation to the measured data. 6 specialists were interviewed. These included 4 prosthetists, a consultant in rehabilitation medicine, and an amputee specialist physiotherapist. They had combined over 140 years of experience and were located across the United Kingdom. When asked about how current assessments are performed, a range of objective outcome measures and tests were highlighted, but there was no consistency between how these were used at different centres across the country. And it was agreed that subjective assessment dialogue with the patient has the biggest influence on K levels. 4 key differences were highlighted when distinguishing between a K2 and K3 patient. These were being able to change cadence, being able to traverse different terrain, walking without a walking aid, and being able to cover a greater distance. When asked about how K levels changed, it was agreed that it takes about 6 months to a year after amputation for K levels to settle. Even with settled K levels, patients can move K levels. Motivation can inspire patients to move up K level, and age and health are 2 big reasons someone might move down a K level. 3 main issues were brought up regarding current assessment methods. These were the definition of the K levels are vague, and that the boundaries are not very well defined, the subjectiveness of the current assessments, and the reliability. A few positives were highlighted about past studies the interviews has participated in. These were that K levels have been changed due to the data that has been recorded. The data has motivated patients to be more active. Clinicians have been excited about the new data that they have received about their patients, and that most patients are willing to be monitored. Three negatives were also highlighted. These were that a single accelerometer on the shank of a prosthesis could not distinguish between sitting and standing, or if the prosthesis is being worn. The feedback of the data was also criticised for being too complicated and not showing the most relevant data. And the cost of the monitors was also a reason for one study not continuing. When asked about the data, the interviews with desire from a new sensor-based system, 5 variables were mentioned. These were step count, cadence, the terrain a patient is walking over, wear time, and distance covered. It was emphasised that the feedback of the system should display the relevant data clearly. It was also highlighted that real-time feedback could have potential benefits in motivating a patient to be more active. A few further considerations were raised concerning patient consent, the weight and size of the monitor, and how the data could be used, which highlights the need for baseline values for each K level. The source of the main issues with the current assessment methods come from the subjectivity and variability of the assessments. There is also some variance in how clinicians interpret the K levels. The ability to change cadence, traverse different terrain, walk without an aid, and cover a greater distance are the main difference between a K2 and a K3 patient. Cadence, distance covered, along with step count and wear time have been measured with sensor-based systems, but identifying different terrain and walking without an aid have not.